And so welcome to the 2015 HealthTech Conference. We're going to be discussing today the lessons that we learned 2 weeks ago at the conference. With me is Carl Boutiet. My name is Anne DeGheest. I'm the founder and managing director of HealthTech Capital and the founder of the HealthTech Conference. And Carl, please introduce yourself.
Good morning, everyone. And my name is Carl Boutiet, and I'm the chair of the screening committee for the HealthTech Capital. And it's great to be here with you this morning.
So we are going to try to keep a timeline of around 60 minutes, but if we have extra Q&A questions, we will stay there a little bit longer if needed. I'm going to review some of my keynotes that several people had requested. We're also going to do a top 10 lessons learned from all the different panels, and then we're going to open this up for Q&A. So you should see on your screen a Q&A area there. Please feel free to type it in. We will monitor it, and probably in 40 minutes, we're going to be starting looking at them and answering them. So the conference was a big success. Not only did we get a great rating from the attendees, we had 410 attendees, and we managed to achieve what we're looking for, which is to have a combination of entrepreneurs, which were around 39% of the attendees, some of the key investors in health tech, large corporations, a lot of providers, especially from the West Coast, and some payers and services. We had 48 speakers and 46 exhibitors. And for the first time this year, we organized matchmaking where young entrepreneurs were able to meet VP of Innovation from 24 leading companies, including some of the biggest providers systems on the West Coast, as well as leading companies on the technology side like Qualcomm, Philips, GE, as well as some of the payers like Humana and CMS, and some of the big pharma companies like Genentech, Merck, and Johnson & Johnson. We had over 250 matchmakers that we facilitated on the morning of October 27. So I'm going to go over some of my keynote slides. And one of the big things I've learned over the last 30 years as both a serial entrepreneur, a venture capitalist and investor, is that the way you build really large disruptive company is to really pay attention to the customer needs better than they can understand them themselves. And what I mean by that is that if you really focus on what I call the hassle maps, the unmet needs, the workflow, and the power shift that's happening in healthcare, you're able to identify new business models and new solutions there and build barriers of entry with those business models. And right now, the disruption that's happening in healthcare is on a scale absolutely unheard of. We're going to be reviewing today who are the new care customers. There's a major power shift about who is making decisions and who is buying the product as well as who is using the product. Who is paying is one of the biggest challenges in the space. We'll go over that too. The other thing that's a key point that came across in all our panels is that people don't buy technology. What they buy is a solution to a specific pain point. And one of the big changes that we see happening right now, we'll spend more time this morning, is the fact that people don't want to buy a tool. What they want to buy is a tool solution, which may include what I call technology-enabled services, which is providing a full solution there, and we'll talk about some of this application. As a result of that, there is new business models that are emerging in this space that should allow entrepreneurs to come up with very disruptive approach and also have faster market traction. So one of the things that's happening right now in this space is a massive restructuring. Not only do we see provider consolidation, but also the payer are really going from an oligopoly to certain states close to a monopoly there. But we have also new entrants who are very, very powerful. We see them on the consumer retail side, and there's a reason for that we're going to see, is the Apple, the Walgreens, CVS, the Walmart, and the Google are coming with full force into the space, in addition to some of the technologies companies like Qualcomm. One of the big things that you need to understand as an entrepreneur investor in the space is that, you know, why people changing and what are the drivers? And on the provider side, for example, the big thing we're going to review is the fact that if you can increase revenue or decrease cost or shift the risk to somebody else, these are the three big drivers in the next couple of years. that will enable providers to basically make a decision to buy new products. And so I think it's very important that when you're looking at your value proposition, that you at least hit one and maybe even two of these drivers. We all know we come from a fee-for-services sick care model there, where the risk used to be mostly on the Medicare, the government, 2/3 of the spending in healthcare, Medicare and Medicaid related, or the self-insured employers there. And really, we come from an environment there where the billable events were basically the patients, and they were perceived to be at the bottom of the pyramid. So we were coming from a very reactive, volume-driven, where we're waiting for people to have an event to be treated. So we are trying to turn the pyramid upside down. So we come from an environment there where the payers were driving the system there, and the patient was at the bottom of the pyramid, to absolutely do the reverse, which is the patients are going to be driving the system, and we're going to get the primary care physicians a much more critical role in the system. So we're trying to move into a future of healthcare that's consumer driven. And what I mean by that is that we're saying to see the accountable care organization or bundle payment there, which is shifting the risk. This whole concept of risk shifting is really important there, because at the end of the day, where we're going is really shifting the care to the consumers. And we're doing this by getting them on this private exchange where they have higher deductible. Congress is trying to pass a law putting a maximum of $13,000 and $700 to the maximum copay and deductible that a family can pay per year, which is pretty stunning considering where we came from a couple of years ago. As a result of that, there is a restructuring of the industry there, where we see an alignment through acquisitions or through formal relationships between the primary care physicians, the specialists, the home health agencies, and the hospitals there. And as they're getting coordinated and aligned, they are starting to basically putting pressure on their own suppliers, which is the medtech and the pharma industries, to start aligning the risk and how they sell their products to these new coordinated care providers. What does that mean when we look at the payment models there? We come from a fee for services, which is still over 50% of the payment in 2015, but it's changing very fast, to coming up with this concept of accountable care organization. The early accountable care organization were basically fee for services with an upside where you share some of the savings. And now we're moving to people being forced to be at risk for the downside in addition to the upside, and moving also to what's called a bundle payment of care for an episode of care. For example, in hips and knees, the government just released yesterday the fact that all hospitals in around 67 regions in the country will have to be paid on a bundle payment basis there. And as a result of that, you see the way we look at the relationships between the providers is forcing the silos to be broken, where we go from separate offices, physicians' offices and hospitals, to force integration of all these entities there, so that they can manage this risk and they can manage the way they provide care to generate savings and share between all the different collaborators. Why is it changing so fast? Here's a very interesting slide, which came from Health Catalyst, that shows that we came from an environment where only 6% of the hospital's revenues were at risk, to expected to be 46% next year. And the big drive is being driven by CMS, by forcing pretty much all these hospitals to be at risk. It is expected by 2018, 90% of the payment by CMS will be under some type of value-based performance pay. So as a result of this drive, the industry has come up with what's called the triple aim, which is how do we measure these quality metrics? And we first initially started with clinical process, but now in the next couple of years, we're going to change the emphasis to using quality metrics that measure patient experience, outcome metrics, and efficiency measures. Again, cost savings and better outcome being the drivers. And better outcome doesn't mean at the event or the procedures level, but at the level of the patient's life. So as a result of that, what we see is the provider industry consolidating. And we see a lot of merger and acquisition activity between the hospitals. And the other thing is that they're buying physicians' practice. So for example, a study in 2013 showed that for every dollar a surgeon makes, he generates $4.65 revenue for the hospital. So really controlling the surgeon reference flow is important there. And the other thing we're seeing is the health plan, now that they have the hospitals and the physician integrated there, are starting to sponsor their own health plan. And we have gone from 200 to 400 in around 1 year time. And so they are starting to negotiate direct relationships with the self-insured employers, as well as getting direct contracts with some of the Medicare and Medicaid plan. And as a lot of you on the West Coast knows, people are trying to, in some way, emulate the Geisinger and the Kaiser model there. So as a result of this consolidation, it has an impact on people trying to sell products to the hospitals. Suddenly, people are now selling to regional systems. The providers are looking not just at services at the bedside, but also for the clinics that they have purchased or they are working with, as well as to the patient pre-op or post-discharge in the home. We're talking about providing the right care at the right time, the first time. Up to 30% of diagnostic is being repeated because there was no integration and an ability for the physician to get access to it at the right time. And the other thing that came up for the first time this year is because the system now gets so big, it's a big question on the entrepreneurs that are they able to scale up from the first pilots in the first hospitals to be able to scale up and being able to be deployed in 30 or 40 hospitals across multiple states. And that is putting an extra burden on entrepreneurs that they need to scale up much faster than they used to. What does that mean from a provider perspective? It means that they see their revenue going down, and it is going down for multiple reasons. One is that through this payment system, Medicare is paying less than they used to pay. In addition to that, as we're moving patients to be treated on an outpatient basis or at home, that means there's less volume coming into the hospital. So how does a hospital respond to that? And what we see, which is really important for entrepreneurs as they try to assess their business model, is that the first driver is to decrease cost in the operation. They're still providing sick care. So any type of value proposition that decrease cost is something of interest to providers. The next level is improving care coordination. Having a total solution there that take care of the patient pre-op, post-op, and making sure the transition of care is effective so the patients can come back within 30 days and you have a readmission penalty is very important. The third one, which may take a couple of years, is to decrease the clinical variability at the point of care. And that's the fact that, like Medicare has discovered, that if you do a hip or knee surgery, there's a difference between, and the variability between $16,000 to $30,000. And for the type of procedures. So, and the fourth one is proactive health engagement, call it population management, where you identify ahead of time somebody who is at a higher risk and may therefore justify an earlier clinical intervention there. So what that means, if I look at opportunities in the space, is provider 1.0 is value proposition that decrease costs all the way from the hospitals to the clinic, where we're looking at the full episode of care, from pre-admission to surgery, discharge, and rehab. And more hospitals are now looking at the longitudinal patient view, not just at the cost per department. It means that they're looking at evidence-based necessary care, which is a new terminology I heard this year, which is help me centralize my back office. Help me improve my compliance with regulatory and quality metrics so I can optimize my revenues, because that's the way I'm being paid today. And also help me consolidate my supply chain. As these systems are getting bigger, they don't want more suppliers. If anything, historically, they have a tendency to decrease the number of suppliers. Again, putting a higher pressure on entrepreneurs to be able to show that they can scale up and deliver. So provider 2.0 is really going to be focusing on getting all this information coming from multiple electronic records, the primary care provider, the specialists, the ER physicians, the home health, nursing homes, into health insurance information exchange that will be into what's called a very large clinical data repository there. The new thing that's happening there is that it's providing this care manager or this patient navigator. And this is really somebody who doesn't have to be an RN, but is providing some tools to help the patient transition care, at the time of discharge, making sure they get reconciliation of their medication, making sure that they set up a primary care provider visits. And what they have shown is that you can decrease up to 50% the readmission rate by this high touch approach. So there's a big effort in developing the tools for these care managers on a very high scale volume. Provider 3.0, which we see a lot of startups right now, is really providing the analytics. And where we see there is that in order to provide the analytics, you also need to be able to get the payer data and the claims data in addition to the clinical medical records there. And the objective behind it is to provide the type of analytics that will allow you to decrease the variability of care I mentioned earlier, which is comparing physicians' performance, identifying outliers in the population, looking at workflows and see what's the best practice, and call it comparative effectiveness is the big driver there. Provider 4.0, where we see a lot of startups right now, but is not on top of the list right now of a lot of these providers, is really to take all this data coming out from the quantified self, the monitoring at home, the biosensor that's being there. And a lot of people are very concerned that some of these data may not be as reliable as an FDA-approved product. So they're developing an open API platform that goes into what I will define as a consumer profile data, which is separated from the clinical data repository there. And the idea behind it is to develop this consumer profile data set about what is happening in the home that is separate from what is happening into the hospital. And there's different approaches there. But the big question I have as an entrepreneur is that these markets are not happening very, very fast right now. It's really in the provider 4.0 timeline. So that also includes the high touch component there, which is to have these call centers that leverage this technology. So if I look at opportunities in the space, I see 4 waves of provider technology. What I call provider 1.0, which is the existing technology on the market, which is the acute care EMR, the Epic, and Allscripts, and all of that. The new technology that is getting good traction right now are technology that help that short-term objective there, which is improving revenue optimization, which could be done there with better quality metrics trackings and all of that, or decreasing cost by providing better patient coaching and better care coordinator, or anything that has anything to do with better provider productivity. And at the conference, we had 3 vignettes focusing on that, Augmetics, Lean Task, and we're all focusing on provider productivity as well as DICOM grid. So provider 3.0 is really decreasing that variability of care, which is providing better decision support for the physicians or the nurse and starting to look into more predictive population. And then provider 4.0 is defined, in my view, as the holy grail, which is your personal health record with your own genomics, so you really personalize all my medical information in a way that I can engage. And this new market that's emerging, we'll talk more, called digital therapeutics, digital diagnostics in the home, to allow you to manage your health at home with all the patient decision support tools. So one of the things that just came out a month ago is this CaliforniaHealthCompare.org. And I really encourage you to go there. It's absolutely fascinating the amount of details you can get. There's over 100 procedures in the whole state of California where you can look at quality metrics as well as price for these procedures there at the zip code level and at the hospital's level. You can even drill down and find the penalties that these hospitals had. It's really worth spending some time on that website there because it really improves the data transparency in a way I've never seen before. So big data, lots of talk about big data in the last couple of years. I think the reality check is first, and that came out from our panels, is that first, is the data connected? Number 2, is it clean? Can you compare it? Is it validated? Is the taxonomy the same? And also, this is something that came up recently. is it reliable data? In other words, is this what's called medical grade, which is FDA approved, or consumer grade? Again, that's a new terminology that's come up with the concern of contaminating the EMR with data that may not be reliable. The other question is the so what? What do you do with it? One of the feedback I'm getting from really some of the pioneers in the space is that they find out that there's a lack of business intelligence and analysts inside the hospital settings. When you have a question you ask for that a clinician has, which is why we're having all this hospital-acquired infection there, somebody has to translate that into a technical query that goes into the database. You have to validate that the data output that you get from the database, is correct. So you have to do a lot of statistical and analyst inquiry there, and then you have to translate that back into a so what from a clinical perspective. That ability of managing that is really lacking in most of the hospitals there. But we start seeing a lot of people, therefore, as providing, instead of selling technology, they're providing technology-enabled services to help these hospitals. So as a result of that, when people are developing big data analytics, and one of our, I think, panelists call this a small data, is not just to get it off the ground, is most people right now are focusing on the existing retrospective data, looking backwards, to really maximize revenue, looking at the best quality metrics that help you optimize your payment under this value-based care. There is efforts in doing prospective, which is identify patient at risk and intervening earlier. And really the last thing that seems to have any traction right now is this concurrent, which is what I mentioned earlier in my provider 3.0, really going after improving decision at the point of care, which is quite a challenge because you need real-time access to all the data in a way that you can change a clinical decision at the point of care. So the holy grail has been to get all of these different sources of information, somehow normalize them, get into some analytic engine there so that you can get an actionable insight, so that ultimately we get to what we're looking for is a change of behavior. Would it be a physician, nurse, or a patient there? The reality is that right now the providers have spent a lot of money paid by the government in incentives over the last few years in integrating the EHR with the clinician nodes, but still 70 to 80% of the clinicians' nodes are unstructured. So there's a big effort in using natural languages to basically extract actionable insights from this unstructured data, as well as being able to push imaging files anywhere the physicians are. The claim data are still in separate silos there. And what we start seeing as far as the remote monitoring is that it's really, kind of very specific medical device grades monitors that are being used. Most of what I call digital health, which is the quantified cells, all the tools that a lot of us are using at home, are really in a separate bucket right now. And what we see is some new startups who are opening their platform to be agnostic to the type of devices there and providing an analytics and what I call a call center to look at what I call the exceptions. And when you have an exception, you trigger an alarm that may get a call centers to intervene, and then when something is still wrong, then you basically connect the physicians, and that may be the information that we exchange back into the physician and maybe the medical record there. So lots of action still happening in this space. What it means, I think it's really important, is that the role of the stakeholders have changed. Patients, as we have seen in the past, was very passive, and now by force, by increasing the deductibles and increasing the risk, they are being forced to be active. The physicians used to be individuals practitioner, now they're behaving like a team. The pharma industry used to develop drugs, now they're being put under pressure to provide comprehensive therapeutic solution to a disease instead of a component of the therapy. The same thing is happening for the medical device industry, which is being forced to start selling products that's no longer for procedures, but for an episode of care, and then showing their value. The case manager used to be kind of an afterthought, kind of a facilitator, and now they're being pushed into a primary role in coordinating care. The hospitals used to compete by offering a breadth of services. We're starting to see the concept of a center of excellence where they develop a specialty, and you see a large system who basically pick one of their hospitals to do hold the hips and knees, for example, instead of providing that type of services for the whole system. And the health plan used to be really in an administrative role, and they're trying to shift their business models to be in the analytics information management business. And you see this for a lot of the acquisition or the internal investment that a lot of the large payers are doing. We all know the Gartner hype cycle, where we go from the excitement of the new technology, and clearly digital health and health tech, is going for that. I call the peak of inflated expectations, and the reality settles in. So my perspective is that the medtech industry is starting to realize the world is changing, and you see several of these very large medical device suppliers starting to have VP of health innovation and starting to look into it. I think pharma is a little bit ahead of the game there in really engaging companies there and trying to develop this comprehensive total solutions. I think the patients are starting to realize that they have to take charge, and I think they start to be really effective, but there's a lot of hype in the space on what they can and cannot do and how much they're willing to pay for. I think the hospitals are all busy now executing, as well as the health plan and consolidating. I think the physicians are really at the bottom of the cycle right now. A lot of them, over 50% have sold their practice to hospital providers. And the employers are very, very driven in changing the system. They're the ultimate people paying for the population less than 65 years old. And we see a lot of activity from the large retail pharmacy chains. So who's going to pay is always the big challenge in this space. We could say, well, what about the health plan? The question is, historically, they have had very poor care engagement, and there's a bit of a consumer trust issue that is still there associated with the health plan. The hospitals are still negotiating this hybrid payment system right now, where most of them are still a majority of the revenue under fee for services. So it's to their benefits to keep the volume high, but they know they're moving into the value-based care. The employers, as they're moving their employees into this private exchange for the large self-insured employers, or this public exchange for the people with less than 50 employees there, it is starting to change some of their drives, and we will talk a bit later on about the Cadillac tax and some of the massive shift that's happening there. And then ultimately, the consumer, but we've seen the consumer maybe willing to pay up to $10 to $30 a month. The big issue there is retention long-term and the cost of acquisition. So still a lot of questions about who is going to pay. And now we're going to talk about how to make your idea into a big unicorn, and unicorn being you have $1 billion exit. And one of the things that's interesting is that historically the Valley was good at developing new technology and going after existing market with existing business models. One of the things that's really interesting with this digital transformation there is people have come up with very disruptive new business models as the way to drive change, and as well as some really very disruptive approach, which I would call this architectural innovation there. And think about like the iPod and the iTunes, which was a new technology and a new business models that totally changed the music industry, or for people old enough to remember the .com, the Kindle and the Amazon, and how that totally structured the printing and the book industry. And we see similar opportunity coming up in our space as we're improving connectivity. It allows more business models. So in the past, we were literally selling one product to an individual, and that could be a B2B, so selling to hospitals, or that could be selling a product like a Fitbit directly to consumer. As we're improving our ability of having subpopulations there, even be able to identify one person within a large population there, it has created some of these really very interesting new business models, from peer sharing and crowdsourcing, like we all know, like the Airbnb or the Kickstarters, to the ability like Uber is doing of aggregating services in a way that's very disruptive to an established industry. Mass customization is something that hasn't happened in healthcare yet, but Coke, for example, is coming up with a dispensing machine there that creates your own taste based on multiple variables there, and they're deploying this. And so I'm just challenging all of you to say that don't think you have to sell a product. Start thinking much bigger there, which is software-enabled services or data as a services or anything as a services is an area that's exploding. That can be a very strong business model that builds a barrier of entry and disrupt an industry. The other thing that's happening in our space is the ability of having the data to be much more granular. And as a result of that, what you see is people developing value proposition and companies that allows you to go at risk with that specific individual performance there. So therefore, my business models will say, I get paid, let's say, a few $100s there to deploy my intervention, and if that person within 16 weeks lose a certain amount of weight, I get paid a much higher number there because I have proven that if I hit that milestones, there is a value to the payers, the insurance, or the employers. And so what we see more and more is that as the data is getting more granular and the connectivity is happening, some of these new business models at risk, basically having a big impact in shortening selling cycles into the market space. So key to success, big takeaway is that rethink your customer. There's massive change in their roles and needs. Also, don't see where they come from, but see where they are going. So look where we're going to be in a couple of years when you get the products on the market. Consumers getting more and more powers. They're going to be the user of a lot of this technology, but they're not necessarily the buyers. So really understanding who's willing to pay for what the consumer is using is a big area. As this consolidation of the payers and the providers, the ability of impacting workflow is going to be essential, and the ability of deploying it and quickly scaling up will require some significant investment and probably raising more capital earlier. Personalization is a big theme. We'll talk more about that in our top 10 lessons there, but the ability of identifying who that person is and what they want and how to engage them differently from one person to the other based on their profile is where we're going. And there's a big shift from just selling a product to really developing what I call integrated solution, which may have a service component attached to it. And I want to emphasize a way that I think we're going towards a model there where you just don't sell somebody a product and let them figure out what to do with it and let them carry the risk. Some of the risk is going to be pushed back to the suppliers of this new technology to say, well, if you think it's so good, why not you go at risk? And with me as a partnership instead of that buyer-seller relationships. So in summary, as we see a massive restructuring of the industry at both the providers and the payers, the good news, we're breaking the silos, there's integration, but then it brings the question of scalability. We're moving from fee-for-services to at-risk, and that's putting pressure on developing new business models to sell to these entities. And we're going from first saving money for better operation efficiencies to improving clinical delivery to ultimately personalization at the patient consumer level. We see a massive shift of the risk from the employers to the providers to the patients, and that has going to have huge consequences in the next several years. And we see what's called the consumerization of healthcare, where we're using data as a way to ultimately change behavior, and it could be the behavior of the caregiver or the patients or the providers. And we're ultimately trying to get to the holy grail to move from a reactive sick care to a health optimization industry. So we had a venture competition, Carl, and we had some awesome people. Hey, welcome back, Carl. Thank you for listening.
Thanks for this great overview, Anne, and for sharing, because a lot of people are really interested in seeing your slides again, because you covered so much content. So we appreciate you doing this. And now one of the things, an exciting event that actually we had at the conference was a venture competition. And we had 4 very experienced judges, 2 traditional venture capitalists, and 2 judges from corporate venture side of the equation. And we actually had a great turnout in terms of exhibitors wanting to participate. We had over 35 companies submit plans, which were reviewed by the 4 judges. And the judges ahead of time looked at the plans and then whittled those down to 10 or a top 10 list. And then during the conference, they actually visited each of the booths and were able to narrow down to their top 3. And the top 3 were Lark Technologies, Fair Care, and Limelight Health. And each of those companies, the CEOs got to present on stage, and that was followed by a 10-minute Q&A or grilling and drilling from our judges. And after much deliberation, the judges came up with a winner, and the winner was, drum roll, was Limelight Health. And there we go. We got a nice picture of them on stage. And Jason is the CEO. Jason Andrews is the CEO of that company. And basically what Limelight Health does is it provides a real-time mobile all-in-one quoting platform for health insurance professionals. And that's actually a $400 million opportunity. And they basically are able to reduce basically a current 2 to 3 week email and paper process to real-time quotes. And that translates to productivity increases of 50 to 70%. So congratulations to Jason and Limelight Health. But in addition to that competition, we also had a People's Choice.
Yeah, and we had this really tight competition there, but ultimately at the end, Care Angel won, the vote of the people in the audience, and we had Wolf Schleichman, I hope I'm saying this right, the CEO of the company, who accepted the award. They're doing something very interesting, again, what I mentioned earlier, which is they developed this Angel, which is a virtual caregiving assistant. Think about Sari for seniors, and they're using a combination of artificial intelligence, voice recognition, to basically have this conversation as kind of a daily check-in calls with the elderly one, and then guide them through a conversation that's personalized on their mental, physical, and emotional well-being. So they not only do medical medication adherence, but really more, the overall health status of the elderly at home. So again, some of these really very creative business models. So congratulations to all for the well-deserved prize. So we're now going to do our top 10, and so
This is going to be David Letterman.
It is going to be David Letterman style. Of course, we're not here retired. So, but let's kind of start first with what we said at the beginning: who pays, why, when, and how. Technology is not the issue. That came across for all the panels, the payers, the providers, is to say, the issue is not technology. If anything, is more technology, we know what to do with. The business model is the problem. And from the employer's perspective, we'll talk more about that. The engagement is the key drivers. The average employer has a 17 wellness plan with an engagement between 3 to 5%. So they've tried this in the past. What are we going to do differently? The payers, we all know historically, they want a lot of data about impact. And so there's a long selling cycles to really move the needle there. Hospitals, we saw earlier, get me some short-term savings. They have very high fixed cost. So it's very important there that the driver there has a hard ROI. And then there's a lot of experiments on getting a consumer business models there, but big issue there we talked about is low price point and acquisition cost. As a result of that, as I discussed a few minutes ago there, we see some very creative new business models trying to break these long-standing cycles by having the startup being at risk and then using that granularity data there to be able to identify the performance of an individual patients there. And then the big focus therefore is what's the right success metrics there. So I think it's important to understand that because it's happening not only to the new emerging company they're trying to break into the space, but that pressure is trying to be also passed down on some of the large existing suppliers, both on the medtech and the pharma side. So now we talk about all these different potential buyers. We're going to go to each one of them. So Carl, let's talk about each of the potential buyers there. Let's first start with the employers. You had a great panel there.
Yeah, we did have a great panel. We had participation from IBM Watson, Grand Rounds, and National Business Group on Health. And employees really have a big stake in healthcare. And they're expanding really from the traditional role of demand side participation as a buyer of healthcare. They're really moving now from that to also engaging on the supply side and really delivering healthcare to their employees. And so why employers really become healthcare innovators is because they have a lot of stake. The first is that if you look at self-insured companies, that's over 60% of companies in the United States today are self-insured. If you look more specifically at companies that have more than 5,000 employees, it's over 90% of those employers are actually self-insured. So it's a big chunk of the market. And really what they're trying to do is change the culture from a health culture where employees are engaged in taking care of their health. Now, with that comes a lot of challenges. And one of them, and we talked about 4 different ones on the panel, the first one is really managing costs. Providing healthcare coverage is important to attract and retain employees, but it's also very expensive. And the cost curve in delivering and paying for that healthcare it's not really been bad. It's been actually continuing to go up. So employers do know, though, that healthy employees leads to reduced absenteeism, and it increases productivity. So they know there's an ROI there. They just need to figure out how to make the economics work. The second issue or challenge is how to add value. I mean, traditionally, they've just been providing health insurance to employees, but now they're really looking at not only delivering health insurance, but how do they get better quality of care for the employees, as well as better outcomes at the end of the day, because that's what's going to impact absenteeism, and that's what's going to improve productivity, and that's what's going to retain employees. And one of the key challenges they face is engagement. Participation in employee assistance program traditionally has been very, very low. So employers are looking to startups and innovation to really drive engagement up. And engagement just doesn't mean logging into an app or participating in 1 or 2 sessions. They're actually looking for engagement that actually is going to lead through a desired outcome. And that's what really matters at the end. That's true engagement. We actually get a benefit from the healthcare, the technology you're providing. In addition, they're also exploring new health plans. Lots of high deductible plans, lots of out-of-pocket costs. So obviously, their employees are more engaged, and looking at different types of plans, private exchanges, providing in-office clinics, partnering with the Mayo Clinic. There's a lot of different ways they're looking at what could potentially be next. And that's something that they don't really know what the solution is, but what is next. And there are some things coming up next. And earlier mentioned the Cadillac tax, which is going to come into effect in 2018. That's going to be a 40% tax on expensive plans. And that's obviously going to cost a lot to employees, because employers are going to have to do something. That cost has to go somewhere. Either they'll have to pay for it or they'll have to shift to employees. And if you're in the Silicon Valley, that's going back over 60% of employers. So it's a real cost that they're trying to figure out what the right balance is between employees as well as the employers paying for this. The other thing is also pricing transparency, which is a good thing. As consumers, and Ann pointed this out, we're all becoming consumers of healthcare, and we're participating. Employers are starting to see better analytics in terms of how much their plans cost, but also now, because of these high deductible plans, consumers have a big stake in this, and they're really interesting to see how much each of these services cost. And so we're seeing a lot of startups and technology providing that service to provide that visibility, so all of us can make better choices. And at the end of the day, employers are looking for analytics that's going to help them drive better decision making, both for themselves as they think about the healthcare they want to provide to their employees, as well as us as consumers and employees. How do we make better choices for our healthcare?
So that's the couch potatoes. Is that the one you're talking about?
So really, employees they've got lots of different types of employees. Anything from the self-starter that already has his Fitbits and exercising to the couch potato that maybe needs a little bit more assistance, to get them taking care of their health.
So now we're going to be also talking about the next potential stakeholders that is willing to pay for, which is the payers. And this is really, we had this value-based care panel there that was really, very interesting there, because this is their own words. There's lots of different experiments on a massive scale. And massive scales, where CMS is putting this pilot there with $1 billion worth of providers' revenues there, and tens of thousands of patients being in these pilots there. The one thing that we have learned is that the traditional ACOs, which was just with the downside being protected under the fee-for-services volume and then just having an upside, is not working. Last year in 2014, 75% of the hospitals in those accountable care organizations there did not generate enough savings to get any type of bonuses. So what we see is a massive shift that is happening there, where the government wants to get 90% of the CMS payment there by 2018 that has some type of performance base, and really focusing now on getting people having a downside risk. And we just got a release yesterday by CMS on the final rule for the joint replacement. And this is a big deal, because hips and knees were around $7 billion of cost to the government last year. And CMS saw a variability of cost between $16,000 to $33,000 in the same regions. And so now what they're going to do is to basically pick episode of care, and then they're going to basically have a flat payment for this episode of care. And they're going to provide incentives for care providers to participate and work together. This is their big drive, is to say, we want you, which is the hospitals, the surgeon, the anesthesiologist, the skilled nursing facility, the home healthcare providers to work together. And one of the big new words you're going to hear is the word stop loss. The stop loss means that I'm going to get a downside if I don't deliver, but I'm going to minimize my downside in the first year, and then it's going to get worse over the next 3 years. And the big thing is that the private sector, like Carl just explained there, I start to be doing this. You've seen people making deals with the Cleveland Clinic, where, for example, I think it was Lowe's and Home Depot there, we're able to negotiate a 25% lower cost for a lot of cardiac procedures there by going directly and flying their employees and their family there to the Cleveland Clinic there. So big change happening in the space, but remember, from the payer perspective, they're still doing sick care operations there. So any type of solution there that can integrate the data that already exists, not necessarily creating new data, but the existing data comes from the payers and the providers there, and providing better analytics there. Providing peer comparison. Remember, the big thing as we're going into this bundle payment and these flat payments, there is that you have to be able to compare to something to know what the payment is. And also you can do comparative effectiveness to find out what's the best practice there, and then putting pressure on all the different providers there to change the way they practice healthcare. That is a combination of high tech and high touch. The other thing that's also coming up is that we're not just patient focused. The caregiver or the care providers is the short-term focus there, and be able to save money, and especially as we're moving to this new type of payment system there. So what about the third stakeholder, Carl, the providers?
Yeah, let's talk about the third stakeholders. And we actually had a couple of panelists talking about the provider. One was about selling to providers, and the other was about the provider's need.
Selling, I thought that was a banished word.
It is, actually. That's the first thing they did. And there was, during the selling to providers panel, there was actually 5 things that came up. And the first one is stop saying selling, because they don't want to be sold to. That's a bad word, because it implies you bring a widget, a technology, something, drop it off at the door, they send you a bill and they pay. They are looking for solution partners. They don't want to be just a technology buyer. They're looking for startups and companies that can work with them to figure out real solutions. So that's the first thing. Don't try to sell to healthcare system. You need to be a partner. The second thing is, we talked a lot about pilots. A lot of startups that we hear from, it's like they're willing to offer free pilots to any kind of healthcare system, and that's not going to work. Basically, they get healthcare providers get 50 to 60 different companies that want to come to them with the app that's going to solve all their problems.
In fact, there was discussion, sorry to interrupt, but during the provider panel that, I think Stanford says it cost them over $1 million now to do a free pilot, because they measure the impact on the workflow and the fact they have to assign people to do that. So a pilot is never free. It has a cost to the system, and they're no longer willing to do that unless they're partners.
That's right. And that's why I mean partnership, that means something very different than just walking in the door and doing a pilot. So pilot clearly has a cost, and it's complex, and you got to be able to scale. The other thing also that they commented on is oftentimes they'll have a lot of startups that come to them and have great ideas, but they don't really understand the workflow. Impacting the workflow, a delivery system impacts patients, impacts the hospital, impacts physicians, and impacts the staff. If you don't understand that, it's not going to work. So part of design a pilot is really understanding. That's your job as a startup or entrepreneur, to understand what that workflow looks like, so you can basically be able to present your opportunity and be able to validate in a way that's going to make a difference. And the fourth thing they talked about is really having a clinical champion. You need somebody in-house, in the hospital, at your customer site, to really understands what you're trying to do and can be the voice of your company, the voice of your solution internally after you leave. That's critical, to have somebody in-house really to push the solution and push it forward. And finally, they're talking about goals. It's really important to have the right metrics, if you do get to the pilot scale, that are going to be able to be measurable and show a return. Sometimes there is reimbursement, but sometimes there isn't. So you've got to be able to show an improvement in outcome, improvement in access, improvement in quality, some kind of metric that matters to your consumer.
You used to call this ROI?
ROI would be a good term, yes. And so the other side, we talked about the provider needs. There's a lot of things that are important to the provider, but one of the key things is being able to integrate your solution and scale it up. A lot of these systems, we talked about that, they're not homogeneous. There's a lot of differences in terms of whether they're fee for service or value-based care, and everywhere in between.
Well, they also have different EMRs because they're just buying them up.
What's an EMR?
That's true.
I mean, you're right. There's all kinds of different EMRs. There's alternative different systems. There's all kinds of different IT structures. So you need to be able to understand that once you do a pilot and once you agree, the expectation is that you understand that you're going to be able to scale this up because they have a lot of facilities that this needs to be scaled up if it's going to have an impact. Now, in the short term, Anna's already mentioned it, we're still in a improved sick care. So there are still opportunities in the short term to improve physician and nurses' day-to-day workflows. Right now, Medicaid, Medicare are 2/3 of the cost. There is room for improvement in efficiencies. Small data, we talk a lot about big data, but even using small data analytics can make a big difference to solve a very specific problem. We saw that through some of our vignettes where Lynn has a very focused pain point. And the bigger the pain point, the more open they're going to be to looking at your solution. And then finally, palliative care. That's a really expensive cost center for hospitals. So anything that can help them manage palliative care outside of the hospital or the emergency department is an improvement. Now, ultimately, it's all about the consumer, and that definition of a consumer is being reframed.
Yeah, and this was really interesting. It came out of several of our panels there that a key point came over and over again, which is we are consumers, we're not patients. 99% of the time we are consumers. We're not defined as a breast cancer person or a kidney disease person. Our goal in life is to basically optimize our health, enjoy our life the best way we can, and we just want the right tools to help us manage whatever body problems or disease we have. And I think that was a very interesting comment that as a result of that, the type of solution we're looking for is that don't bombard me with all the things I'm doing wrong. Just give me the right information at the right time, at the time I'm supposed to make a decision, so that hopefully I make a better decision. And so this concept again of pushing information that's personalized to me, which give me the right coaching, which is the high-tech, high-touch concept there, is really where I think there was a couple of, I think, what I call big surprise about how this market is being redefined. And I think as a result of that, this new sector called digital therapeutics is this combination of using personalized information at the right time to hopefully impact therapeutic intervention, Carl.
Yeah. So there was a lot of discussion about digital therapeutics, and as we move from sick care to consumer-driven care, we're moving outside the traditional hospital, the clinic, or physician office. And innovative companies are looking to leverage basically immersive remote programs to change patient behaviors at the end of the day. And they're trying to do that in a setting that is not as expensive. They're really trying to figure out, we talk a lot about engagement, but it's engagement to a change in behavior for better outcomes. So they're looking to tie patients to healthcare professionals, payers, and even pharmaceutical companies, as Anne talked about earlier. It's not just about giving a prescription, but to make sure they adhere and maintain that prescription. And they're looking at all kinds of different multiple modalities, anything from telehealth, texting, real and artificial intelligence coaches, remote monitoring of weight, activities, sleep patterns. There's a lot of things that they're looking at when we talk often about the quantified self. And that's really here and expanding, and they're looking how to leverage this. And one of the key areas healthcare providers are interested in is this chronic disease, which has huge costs. You can have remote management for pre-diabetes, diabetes, smoking cessation, cardiac care. All of these have opportunities to manage a population in between hospital visits, which are very expensive. But how are we going to accomplish this, Anne?
Yeah, I mean, this is interesting. I mean, the panelists was very excited to say that up to 75% of chronic disease management should probably start falling into these new platforms. And I think the key that all these platforms had, and the panelists was really awesome there because we had very different approaches, is they all had one thing in common, which I call behavioral science, which is really emerging as one of the big drivers to enable this personalization there. And they all have this combination of high tech and high touch. So they were using technology to extract information, and then they were pushing it back using a combination of coaches, virtual coaches. Some people were like on the web as real people there, but pushing information there. Some using some type of artificial intelligence coaching there. Peer pressure group, like the Weight Watcher or the Alcoholics Anonymous there. And then depending on the type of application they're going after, some were adding medical device, grade FDA-approved products, like, Gluco was using a product for glucose measurement there, and some were even using new drug delivery there. So it's basically all packaged and integrated together. So in their case, they were doing for people trying to stop smoking, and the cravings, it was starting, before you get up in the morning there. So they were releasing the nicotine a couple of hours before you normally wake up. It's having all these little pieces there in my daily lifestyle that they integrated together, so I can continue to do what I do as a consumer, which is manage my life the best I can and manage that disease in that context there. So the big question is that how are we going to do this, and who is going to pay? That is still, as we've seen before, we see a multitude of different approaches. Several of these companies are selling to multiple entities, both the health plans as well as the at-risk providers as health insured employers. And what is interesting is that the value proposition they have is slightly different. The metrics they're using different. They all have one thing in common at the end of the day, which is cost savings. And then you have to look at how you price this. You have short-term milestones, what's the long-term maintenance cost. So there's some very creative things. It's an industry that's there, that's going to emerge and be, I think, very, very large, but it's still in its early stage.
So really the question is, do these digital therapeutic tools, do they fit everyone the same way? Or is there something better that can be done?
Are you trying to tell me you're like me? I mean, my haircut is better. Just kidding there.
Yeah, mine's low maintenance.
So, okay, I won't touch that one. So we had a personalization panel, which was really focusing is what can we learn from the traditional digital media world that can be used in helping, really personalization, patient engagement there. And I think what was really interesting that came out from our panelists there, that the key to understand consumer behavior is why do they engage? And it turns out that not all of us are the same. I like shampoo, you don't, for example. Just kidding. And so really understanding the why helps you define different subsegments. And as a result of that, it's the drivers are not rational. So we come from an industry there that, we need the facts, the FDA is very good at telling us black and white, there's no gray zone there. Well, the consumer is all about feelings. Is how I feel is based on what is important to me, which be different from one person to another. So really defining subpopulations there based on what are the drivers, what type of feelings they're trying to engage is what helps you change their behavior, the do part. And what is interesting is that there's new technology emerging to help use of consumer data to be able to identify predictive modeling of personality type that we can use in the healthcare engagement side. And remember, all of us are really busy people. The other thing that came up is that it's not a one-time silver bullet, I get your attention, now you change for the rest of your life. This is something like McDonald's has shown us, unfortunately with the fast food industry, it's an ongoing effort. So the branding and the way you communicate and the way we basically get people to change behavior that is sustainable over a long-term period of time means that we have to continuously interact and push this message to the consumer there. Therefore, all the solutions there have to start thinking about a continual engagement loop, which may be different initially when you get their attention, let's say after you had a surgery, to the long-term maintenance there. So the question is, as we start to really having this new word called behavior, technology there, does that mean we have now a new market called mental wellness, Carl?
We do, but speaking of behavior, I do like shampoo just fine. I just use it a lot less. But I stray. So back to one of our key panel, we had a great panel about digital mental health. And the first thing that we talked about is really about the definition of mental health. And that can go from all the way from the spectrum of mental wellness all the way to mental illness. And some of the facts that came out is that according to the Center for Disease Control, only 17% of adults are considered to be in a state of optimal mental health. And 26% of the U.S. adult population is affected by mental illness. That's over 1 in 4 of us, with the most common type being depression. And the U.S. Department of Human and Health Services estimates that mental health and substance abuse cost $239 billion in 2014. That's 10% of all healthcare expenditures. It's a really significant issue. And one of the things that we talked about in mental wellness is really that behavioral health is an underserved opportunity. And there are a lot of problems and challenges. The first is that there's a mismatch between the patient, demand for physician and specialist, and the actual supply. it's really, really a huge gap in terms of providers and patients that need the service. The second is the stigma. Obviously, there's a lot of stigma associated, and there's really no clear mental health pathway for folks that have an issue with mental illness to be able to access this. And over 50% of people that are impacted by mental illness never actually seek care. And the third key challenge is really reimbursement. The clinician's time. That's reimbursed today, but not many or hardly any of the digital tools today are actually reimbursed. So if we talk about the needs, really there has to be an optimized clinical workflow. If this is going to be an efficient process for folks to actually have access to the technologies and other types of services, we need to optimize the clinical workflow so that we can leverage the available specialists. Second, people are not traditionally asking or seeking for help. And there's actually a lot of different companies that came up and provided some interesting ways where we're talking about asynchronous texting, not necessarily having video face-to-face because people are not as comfortable talking live to a person about their mental health issues. Sometimes they certainly don't want to do it from home because maybe they don't want their family to know that they're talking to a physician or a specialist about mental health issues. So there's a lot of different technologies that are looking to improve the access and make it easier. And third, one of the key pieces is collaborative care. 80% of folks that have mental illness challenges actually are seen by primary care physicians. So that is a key point that we need to figure out how to leverage that touch point and expand the care. And we saw actually a lot of new different approaches. We saw text messages, both asynchronous and synchronous. We saw video sessions, and they both have their value. We also saw some companies like Mental Health talking about behavioral population health management. We see this in diabetes, and now it's expanding to different types of groups. The key, though, at the end of the day is we need to treat the whole patient. It's not just a digital solution. It has to be a digital solution with the human touch to really create some effective outcomes.
Yep.
And now we've kind of defined a lot of the issues about business models and market drivers. How do we scale up or help companies scale up to be successful?
Yeah, I think the first thing that's really unique about the space, and we had the workshops on partnerships, is that in health tech, we've seen earlier partnership that we've ever seen in our traditional medtech and biotech. And so we had a very interesting panels there with, the large tech providers as well as, several entrepreneurs. And the thing that came across was, what are some of the mistakes that people have made in the past? One is for the entrepreneur to go too early. And one of the problems is that when you see somebody and you don't really have all the answers and a large corporation is looking at you, is that you have this first impression that's very hard to change afterwards. So if you come too early, and you look like a young puppy there, you're going to look like a young puppy for a long time. The other problem that came up, and that was a perception of the very large strategic, was that do not become too dependent of your partner there, because if something goes wrong, that could be fatal to the company. A big mistake that all our panelists share is that don't expect the partner to figure out how to sell and figure out the business model for you. They won't. That's not their strength. They're very good at scaling up something that has been proven. But use them to learn about your business channels there, but you still own, and you have to demonstrate, what the revenue model is. And this is an expression I had never heard before called startup tourism, not to be confused with medical tourism. And startup tourism is that people love to talk, and we've seen a lot of entrepreneurs wasting a lot of time, talking too high and be shut down very quickly when they go downwards, or getting too low with people who love the attention there, but not really getting to the decision maker. So really do your homework about who has the budget, who has the decision-making process there in these large entities. Partnerships, let's get a reality check. It can take 14 to 20 months from the time you basically have the first contact to having the trust where you start implementing things. A lot of people suggested to have field collaboration before you have formal partnerships, so work with them, develop some maybe activities together, co-marketing with maybe somebody in a region there that wants to work with you. And then really making sure you understand their needs and align the interests and goals. Very often, the entrepreneurs try to push their goals, not understanding there may be a conflict with the goal of the large entity. The new concept is the same way that we're doing with fundraising. Get a term sheet discussion early. Just find out between business people what are the key terms of a successful partnership. Negotiate what's called off-ramp. if something goes wrong, you don't hit certain milestone and all of that, how do we get divorced in a way that doesn't kill the company there? Very important to have multiple of those. And then understanding this is not a one-time thing where you just lock one big guy for a lot of money there and this makes your company there. This is a flexible and living documents there that you will change and modify. So the document is a way to force communications of this interest and these goals, not a way to lock somebody into executing something. And there was an interesting comment from one of our panelists there that in health tech, there's really no strong IP like you will have, for example, for a new drug or new medical devices there. Very often, the intellectual property is in the brain of a lot of the key employees. So in addition to the NDA, they really had a no poaching clause as they start going to this deep discussion there because they didn't want the large entity to basically hire away some of their key, contributors in the company there. I thought that was interesting. The next thing is how do you scale up? We had some really great panels on that. And one of the key comments that came up is that if you're a market creator or market leader, you define your own language. You don't wait for the market to say, I have a need. You basically anticipate where the market needs are going to be. It's like in hockey, you basically go where the puck is going to be, except that you're the one driving the puck. So you can create your own market and define them. And this is the way you can build,
they gave us some great example like Starbucks, I don't go to Starbucks very often, but if I go in and ask for a regular cafe latte, they look like me like I'm crazy.
Yeah, thank God I drink tea, but that's okay.
But those are the kind of examples you create your own language in your own terms that makes you unique.
The next big thing is the right culture. I mean, all our companies are we all know as an investor there, basically it's the people there. And, one of the key comments says hire low, fire high. Basically hire people who have the passion. So they don't want very high salaries, you hire low salaries there, but they have the passion and the value, the stock options, retrace and alignment in basically building the company. Firing high means when people leave because they couldn't grow fast enough or something did not work out, and you terminate there, they will be your ambassador in word of mouth. So, take good care of them. In creating a community. And the key that people are looking for when they're building these first initial teams is the 3 Ps, which is, do these candidates have the persistence, the passion, and the problem solvers? Is this their personality there? And as you're creating the team building there, both of our serial entrepreneurs there building their companies there says that 1/3 of the CEO time should be focusing on team building there. That means they're trying to identify people who fit the team. Go outside the traditional interview setting. Go out for lunch and dinner with the partner or the spouse of the candidate there. Don't just use the reference checklist that they give you. I mean, nobody's going to give you bad reference if they're on the list there. Go outside. Ask a question like, who should I best pair with this person to build a team? That will tell you the weakness that people don't want to necessarily volunteer. And this is a very interesting comment that came up, which is don't fire people for mistakes. The whole idea in the early stage of the company is to make quick decisions, move the balls, learn, adjust, and correct. And so talk publicly with the team so that you can learn and don't crucify the person for making mistakes. Have the whole team learning about, why we made the decision, what are the lessons we've learned, and what we should do differently as a result of that. And then I want to finish in the last comment, which I thought was interesting. When they interview you, they look to see if you're cleaning behind you in the conference room, and that shows kind of team spirits, the caring, and the respect. I thought it was an interesting little comment there. So we're going to open this up to the Q&A. So I think if you could make sure that you have lined up all the Q&A questions there, and we're going to open this up. I'm going to try to see if I can open this up. So as
part of the webinar, there should be a box where it says Q&A, and if you go in there, you can type in questions that we'll be able to see.
There's no question. They love us. So please type it in. One question is that if I'm a health tech entrepreneur, what are a couple of areas where I will be having a high probability of success in developing a startup? Well, I think honestly that's a tough one, because if I knew and it was a sure thing, I think I would be doing it. But I think we have explained earlier, I think as long as you focus to what we discussed multiple times, which is make sure you understand the hassle points and who the stakeholders are, the value proposition, what you have to prove them, and then how much money you need, to validate that, really understanding those pieces. And then the technology and the product becomes more obvious. So don't focus on the technology, focus on the pain point.
Yeah, I think the pain point is usually key. And two things. One, the pain point, and the bigger the pain point, the more traction and the more discussion you'll be able to have with your customer. And the second piece is, we talked a lot about that. You need to understand your customer. I know we see lots of great IT solutions, but if they don't fit healthcare, it's actually not going to work. You need to understand the healthcare flow. You need to understand the healthcare delivery system, because it's very different. These are FDA regulated environments, so it makes a lot of difference in terms of how they provide patient care. And if you don't provide patient care correctly or impact their workflow, and you don't understand what that's going to do down the line, it's going to be difficult. So understand the pain points, understand the workflow, and find a customer that has that huge pain point, and that's the one that's going to be really talk to you.
Another question that came up, which is, how will the overall industry change from this year to next year? There is no doubt that, I think as we discussed earlier, that 2016 is going to be a pivotal year. You see massive transformations from some of the big people who are willing to pay for. First, the government is doing this massive shift of the risk through the bundle payment of the hips and hips and knees, and making it very clear that's the way we're going for other procedures afterwards. You see a change in the self-insured employers moving people really fast into this private exchange. I think it's estimated up to 40 to 50% of the employees in this country are going to be on public or private exchange in the next couple of years. And in addition to that, you have this Cadillac tax, which I think is probably going to speed it up. And so as a result of that, I think the openness for people to try new solutions is extremely high. I think it's the highest I've ever seen for people to be open-minded, to look at solutions there. The challenges is that, as you're getting the solution there is to get above the noise level, because everybody in the brother is knocking on their doors. Carl, do you have any thoughts?
Yeah, I think the other big change also is that the consumer, we talk about consumers and patients, and that's us. And at the end of the day, we're going to see we're going to need to be a lot more engaged, because there's almost a lot of the plans are high deductible plans. And so we're going to need to make better choices. The challenge is oftentimes that's difficult to do because the information is so confusing. So I think that's another opportunity where we'll see a lot more transparency in terms of making medical quality care choices, as well as the pricing associated with that care.
Another question that came up is, what's the speed of change? There is no doubt that there's the willingness to change, and then there's reality of implementing these changes there. And I see a little bit of a disconnect there, where I see, for example, some of the early adopters on the provider side at the VP innovation level, all of that with the willingness to really look at new solutions there. And then the implementation still takes 1 to 2 years to do these pilots, which at times can be really fatal for companies who haven't raised enough money there. So I think the speed of change, I think we need to break down the speed of interest of looking at solutions where I think it's pretty high. The self-insured employers, I think it's higher than I've seen in years, probably there. And then we still have the reality check, which is, as you are knocking on the door and you have that champion in there, the reality of grinding and making it happen, going for the bureaucracy, some of the interface that may be needed there, is still, and as far as the ability for the entrepreneurs to get recognized revenues, which is what will trigger the next funding, is still the challenge, what I call the Series B crunch, which is, getting enough of those to prove you have a scalable solution. Carl?
Yeah, I think, when I think about the speed of change, I mean, oftentimes talk about the market as it moves from fee-for-service to value-based care. And I think the latest number I heard is, we're about 20% fee-for-service. 20%, 80% still fee-for-service, and only 20% value-based care. It'd be great to know when we're going to be at 100% value-based care. And I don't know that. I don't think anybody can forecast that. But if you're a company, you need to understand who you're talking to, because if a hospital delivery system is based on a fee-for-service model, if you come in and talk about quality outcomes, of course they're interested, but you know what? People not coming back for procedures is actually declining their revenues, just fundamentally, economically speaking. Obviously, I think all physicians want to do the best for their patients, but you got to understand the economics. And so as you think about segmenting your customers, that's a piece you need to understand, because decisions are based on, obviously, the revenue stream. How do they actually get paid? And understand that piece is going to be key, and it is going to be changing.
Yeah, and I thought what's interesting is what happened yesterday. I think it's worth looking at some of the articles that came up, I think today and yesterday, about the fact that Medicare was going to force mandatory use of bundle payment for hips and knees. And there was like a 3 months response periods where everybody was screaming about you cannot force people, you cannot make this mandatory. And then initially in the past, when people complained to Congress and all of that, there was a change and there was, things being shifted and all of that. And then CMS said, fine, we'll delay it by 3 months. So instead of January 1st, which is really soon, they move it to April 1st, which is still pretty soon in providers' terms. And they said instead of 75 geographical locations, it's going to be 67. That was their compromise. So I think what we see is that is really the change coming from the ultimate purse carrier, which is the government, and over time the self-insured employers to say enough is enough. We're changing it. You're going to figure out how to adapt to it. And I think it's going to be interesting because some system will go bankrupt, some system will be in trouble, and we have to see what's happening to the consumer there with the high deductible. Another question that came up, which is, will we see more use of cool innovation like cosmetics, which is the Google Glasses, or virtual reality in healthcare? I think that, again, I think we need to be careful. We don't look for cool technologies as opposed to solution to a specific problem. I think Augmetics was trying to fix the problem that people don't spend enough time talking to their patient there. They spend all their time, typing into a medical record there and having not really a good interaction there. So they are really looking at cost savings. And cost savings is that they think they can save maybe a couple of hours per day of physician time, which is astonishing if they can continue to deliver that. So I think we need to make sure that the cool innovation is a way to deliver a solution that somebody's willing to pay for. I feel like a broken record here. What do you think?
Yeah, no, I think actually I was on the Augmetics vignette where we talked to them, and what was interesting a few years back, Augmetics were looking to totally automate that interaction, basically take the audio and video feed and make it a two-way and straight into the electronic medical records. And they actually really pivoted where they now actually still use Augmetics so that through the Google Glasses, the physician can focus on the patient. But in the background, there's actually a human person. There's actually a scribe, and that's typing into the medical record. So it does improve the quality of the interaction. It does save time for the actual physician having to type notes, but it's a different interaction than was originally. And that's a key lesson for entrepreneurs. Oftentimes you'll have to pivot within the healthcare system as you learn and adapt to some of the challenges you're trying to resolve.
Yeah, and we just got a comment from one of our leaders from TMS who is on the webinar to confirm that the final rule that we published yesterday was that in what's called the Comprehensive Care for Joint Replacement Program, which is the hip and knees, that it was pushed back to April, like I said earlier there, and the number of committees were reduced, and then also I think what's important, which I didn't go into the specifics, that the first year of the model will not entail any downside risk, and then the downside risk will start going up afterwards, and that CMS is trying to be sensitive to not pushing too much risk too quickly there, so that we don't stress the system too much. So I just want to fine tune what I said earlier there. So please, keep us, keep us with your questions there. We really have enjoyed this dialogue. Otherwise, we'll be doing a recording this, and we're going to put on YouTube. So if you haven't seen last year on YouTube, it's called Lessons Learned at the HealthTech Conference 2014. We're probably going to do something very similar, so make sure you look at 2014 versus 2015, and probably be posted sometime next week. I think I'm trying to see if we have more questions there. And we really thank you for all your time. I know we spent a bit extra time there, but we want to make sure we share some of the insight, I think, with some awesome panelists, and people are also raving about people in the audience, which is all of you, and that was our objective, is to get everybody to participate in this discussion. And so we wish you all a lot of success with your startups. If you want us to help you as mentor or investor, let us know. If you want us to help you and partner as a large strategic in helping you see which way the industry is and how you can partner with a real estate company, we have HealthTech Capital, which is an ecosystem there of members who are accredited investors. A ton of our members are physicians. We also have leading strategic organization that are partnered with us. We know we have GE, we have Philips, we have Merck, we have Johnson & Johnson's there. And again, it shows again that this system, everybody wants to work together in helping change healthcare and hopefully keep us healthy. Carl,
sounds
any
good.
last word?
Thank you for your participation, and thanks, Anne, for helping me help you this year as part of the HealthTech Conference. It was a lot of fun,
and you were great.
Enough.
Thank you very much for everybody, and have a wonderful entrepreneurship experience.
Sure.
Bye-bye.
Bye-bye.